Well, let me start by introducing the concept. I was Sky president now 2019 to 2020, and one of the things I wanted to do during that year was tackle the topic of interventional cardiology training. And it took us a year to get a writing committee together, and we did it a joint working effort between the American College of Cardiology, American Heart Association, and Sky. And this is the first time in almost 2 decades that we tackled training in interventional cardiology. Okay, I'm trying to move my slides, but I can't. Here we go. I had the privilege to be one of the co-chairs or vice chairs with Don Abbott and Sahil Parikh. I was the chair for the structural section, and overall writing committee chair was Ted Bass, and you can see the group of people that were involved in putting this together. We collaborated with multiple other societies, surgical imaging, as well as Heart Failure Society, EP Society, Interventional Radiology, and Vascular Medicine. And the goal was to define the required competencies, procedural, numerical requirement, and training standards for not just coronary, but peripheral vascular and structural heart interventions. And a very important point is we really emphasize competency-based training rather than numerical training, understanding that competencies across the 6 main categories from ACGME are really a core curriculum requirement, and competency for some people may be acquired with lower volume than others, and conversely, others may require a much higher volume of a procedure to be competent. Nevertheless, we did define minimum procedural numbers, which don't mean that you are proficient, but means that that's at least the very minimum numerical requirement to be able to independently perform some of these procedures. Just to clarify for everybody, we surveyed the training program directors in the United States. Ultimately, this publication had 63 peer reviewers. We had a public comment period, which yielded about 750 comments. All of those were addressed, and this was just recently published in Jack and Jay Sky, I think within the last month. So let me talk about competencies. From a competency standpoint, whether it comes to coronary, peripheral, or structural heart, I won't go into the details, but we felt that virtually everything is a core competency for all interventional cardiologists, with the exception of understanding 3D anatomy for structural heart interventions. The rest of them are listed here. And similarly, when it came to the care of patients and management of complications, we felt that for contemporary modern interventional cardiologists, they need to know coronary, peripheral, and structural heart management of complications, understand how to work up the patients, not necessarily do the actual interventions. From a professional behavior standpoint, these are really standard, important behavioral expectations of interventional cardiologists as they are for general cardiologists across systems-based practice, PBL, professionalism, and interpersonal and communication skills. But this is where things get interesting. This is what everybody is really, really interested in. What about the numbers? So previous training standards almost 2 decades ago required 250 PCIs as a bare minimum during training. We maintained that number of 250 interventions, but we have expanded the definition. So 200 are PCIs. The other 50 can be any combination of coronary, peripheral arterial, or structural heart interventions. That's a change from the previous statement. So PCI, a minimum of 200, but a minimum of total of 250 interventional procedures. In addition to that, we want everyone trained in coronary physiology and intracoronary imaging. So at least a minimum of 25 FFR, IFR cases, as well as 25 IVUS or OCT. The training pathway. So this is our central figure for this manuscript. If you don't look at anything else, this one figure pretty much explains it all. 3 years of general cardiology, followed by a minimum of 1 year interventional cardiology fellowship. In that interventional cardiology fellowship, you do 250 procedures with 200 PCIs as a minimum and 50 others, 50 adjunctive procedures, physiology and imaging. Now, what if you're interested in peripheral vascular or structural heart? One very important change we have made is that as long as you've acquired level 2 competency in diagnostic angiography and diagnostic catheterization, you can start your peripheral or structural interventional training during your general fellowship. However, those numbers don't count unless you've completed a coronary interventional procedure subsequently. I'll have separate slides going into the details of the peripheral and structural. The building blocks, this is the other core concept. The building blocks of the profession of interventional cardiology is defined here. For coronary interventions, obviously you need catheter skills. You need to be able to get arterial access and closure. You need to be able to recognize, prevent, and manage complications. We felt the use of atherectomy is a core skill and use of mechanical circulatory support as applicable. Similarly, you see the core building blocks. If you're going to be a peripheral vascular interventionalist, a number of things are similar to the coronary interventions. And on the right bottom, you see the structural heart intervention requirements. I think one of the common themes in this training statement is that there is a lot of overlap between your skill sets for coronary and peripherals and structural. So that is one of the reasons we felt that you can acquire these skills in any one of these 3 domains, and they apply to your overall skill set. What about peripheral vascular intervention procedure numbers? For diagnostics, we define a minimum of 100 with a minimum of 50 interventional procedures, and the examples would be lower extremity, subclavian, innominate, renal, mesenteric, and the treatment of chronic limb ischemia. For carotid stenting, 25 with over 13, i.e. at least half as primary operator. For EVAR,
2 minutes to go.
Okay, 20 cases, and for peripheral venous, also 20. Let me show you structural heart interventions. For TAVR, we defined 50 with 25 as primary operator. This is another important element. If you decide you want to do TAVR in your practice, we did not feel that you necessarily needed broad training in all structural heart interventions. So as long as you are a coronary interventionalist and are trained in TAVR, you can do so. However, for left-sided structural heart interventions, we felt a foundation of 50 lifetime transcatheter structural heart procedures with numerical requirements as listed for all of the various procedures. Finally, we also defined adult congenital heart intervention requirements for adult interventionalists. So we are not talking about pediatric specialists, whereas an adult interventional cardiologist, if you want to do any of these procedures, in addition to your coronary training and structural training, then these are the minimum numbers you must do during a training program. Final slide here, we emphasize that the concept of training in interventional cardiology is to prepare people to be ready for subsequent lifelong learning, because we know what you train in today may not be what you do a decade from now. So lifelong learning, experiential learning was a key element that we emphasize in the training statement. Thank you very much on behalf of ACC, AHA, and SCI.
Thank you very much. This is definitely going to stir some debate because we have a 2-year interventional fellowship over here, and a lot of people don't have access to some of the structural and peripheral interventions. Do they really need to go for just coronaries alone for a 2-year fellowship. And, the professionalism aspect, the system resource utilization aspect, all those things to be built in the fellowship program. But thank you again for the talk and the left main bifurcation case you did this morning. You always, contributing a lot to Park Life. So you're a Lahori as well. So we hope to see you in Lahore more often. And thank you. Have a nice weekend.
Great. Thank you very much for having me.
So can we go to Dr. Naeem so he can show the final results there?
Hi there, guys. Can you hear me?
Yes, we can. We are all eager to see the final result.
I want everybody
there.
to be quiet. Can you guys hear me?
Yes, we can.
Okay. Yeah, so Bilal and Heather and myself, we've been working away. So let us show you what we've actually come up with. Jay, take this camera out and just come up close so they can see the pictures. Can you see the video pretty good, Naman?
Actually not. Can we change we're still on the Dr. Ehteslam's slide.
Come over here, boss.
Now we can see. Now we can, we're going to use. So can we zoom in on your screen there? Yeah.
Okay. All right, let's show the pictures.
So last you were doing, you had the guideliner down and you were planning to dilate
Turn
it.
my
and
lights down, guys.
Going to an
All the lights down.
shock wave is what you were planning to do. So we lost connection. So can you just go over the steps that you, yeah.
How about now? Can you see it better?
So you can zoom out a little bit because you're just seeing part of the proximal circ right now. So if you can zoom out so the distal area as well, yeah, that's perfect now. So I guess this is as good as it will get.
Okay.
So can you go over the steps?
I haven't started showing you yet. So okay. So
after the guideliner,
you remember we got in. So this the wire that is down there is a wiggle wire. We changed out for a wiggle wire.
Okay.
You don't have that in Pakistan. I've been asking you all guys.
Or we lost connection again. So I need a pause.
Yeah, just the angiogram, boss.
So we lost you. Can you just go over the steps that you did quickly and show us the final result?
Okay, so this is shock wave going on. So this is after shock wave. I'm going to show you JSKBT, jail semi-inflated kissing balloon technique.
What size balloon did you use for shock wave and how many pulses did you need?
Huh?
How many pulses did you give and what size did you
use?
We
used all 80 pulses. We used the Arai talked about JSKBT. I've been talking about JSKBT, jail semi-inflated kissing balloon technique. We took some extra pictures here to show you. So you remember this AV groove artery that's going has an osteal stenosis now since we've opened up about 90%. And then the main OM is going down. So we didn't want to lose that. So we got a wire in there. And then I ballooned that. This is just a tube balloon. And then this is what I want to show you. So I have a stent, which is sized to the distal vessel, which is 2.5. And then I have a balloon that is a 2O balloon going down into the AV groove artery. The proximal dot that you see is the balloon. It doesn't have to be proximal to the stent, but in this one it came.
So, we're discussing about the JSKBT. In these calcified vessels, you always worry about, the balloon getting stuck. And we had a discussion on this morning.
So here's my statement. I've done this more than probably most other people. Done this for 5 years.
That's the key point. You do them quite frequently, and you've done a lot of them because, I had 1 or 2 cases shared with me people do get influenced by what you say, and I had one or two cases where the balloon got stuck and that the guide was getting sucked in, and they were referred to me, showed the pictures later on, the artery got dissected. So I think for people who are trying it should be careful that...
Exactly. So the couple things. It never gets stuck as far as I'm concerned. If it gets stuck, you can always inflate that balloon, and that will take the stent away and you can pull it out. But every time you take a gel semi-kissing balloon and
We lost you again. So shockwave, and then you're doing JSKBT, and then can you show the final?
So here's what's happening. So at the beginning, I'm going to put in about 3 atmospheres of contrast in the gel balloon. And then once that's there, then I'm going to inflate the stent. And as you inflate the stent, that contrast that is in the main artery will squeegee into the side branch and will avoid your plaque shift. And I'll right there, and then you will see that contrast going down.
Mm-hmm.
And
paused again.
So now what we're doing is, after you've done that, you take the balloon out, and then you just go up to the nominal pressures to kind of oppose the stent tines that are across the branch. This is what it looks like afterwards. And then this is a long stent going in, and this is a 4030. And you can see that branch, or the OM branch, that looks really good there. Look at that OM branch. That looks good. And when we've stented it, and then I've got the IVUS there, the distal.
Can you zoom out the angio, I guess, to show the distal circ area as well? Do you have a picture with the distal circ as well, how the whole vessel looks like?
A picture right in front of you. Give me 412 over there, or 512.
Yeah, can you show the whole?
Dr. Amr Hamid, I can hear him. He's come in too. All right, so contrast. Okay, here we go.
So very nice result.
Okay,
yeah.
and
Branch is patent, and
we'll show you the IVUS.
Artery. And
can you show us the
I'd
IVUS?
love to see the IVUS run as well. Is this some? So proximally, it was a 4 stent. What is the stent distally? There's some under expansion of the stent in the distal portion, but I think probably.
Yeah, 2.5. You're 100% right. It's a 2.5. We measured it to that. But once we open the proximal area, it looks like it's slightly underdeployed. So we were about to take a 3O balloon. Right there, you see that it's underdeployed?
Yeah.
This is distal to that AV groove artery.
Mm-hmm.
So we have a 3O balloon part there. I don't want to do it across the AV groove. It's a really short one. I'll do it distally. But if you look at the rest, it's really, really nicely set up.
Nicely opened up, yeah.
Yep. And then you can see the stent tines are pretty snug, and pretty happy with all of that.
Yeah, the area looks definitely more than 5 millimeters square. You've got and it looks well opposed. And all right. So great job. And, this is the final picture.
Oh.
Do you have an LA caudal view as well? Just to see the proximal ostial left circumflex?
Yeah, right there. Let's show you a little bit better picture there.
Yeah, I mean, that's really good as well. Just if you're a caudal, that'll be nice, but that's okay. We can.
Okay, one more picture. So if I can do my own table, I can mess with it and I can show you the ostium really good. So we
All right,
rotated
yeah.
that and you can see.
So nicely opened up. Thank you for doing the case. A lot of learning from it, a lot of learning tips and practical points. You demonstrated the JSKPT very nicely, opened the CTO up. It was a high-risk case, low EF, Impella use and everything there. So really fun watching this
Thank you
case and
very
learning
much.
from it. Thank you.
Thank you.
And
Thank
a
you.
round of applause for him. And thank you for always promoting interventional cardiology education with us throughout. And look forward to seeing you in Lahore as well. Take care. Have a nice weekend. We're going to close this session now, and I guess we're going to all meet here at 8:15 p.m. Before we close, I guess any comments from the panelists? Last few remarks, 2 minutes.
Yeah. Heather, come over here. Bilal, come here.
Thank you, Dr. Naman. Great case, especially the last left side CTO with patent LED, patent RCA, and that patient labeled few years back with a non-ischemic cardiomyopathy, which survived cardiac arrest. On opening a CTO of 2.75 or 2.5, what do you think that will help that patient?
So that's a good clinical question. The patient had an EF of 30%, and we didn't have the whole detailed angiogram. They're saying the right was okay, as they reported, and LED slide maybe had some disease, but the reason to go for the CERC was because the ischemia apparently was demonstrated only in the infralateral segment. So that's why the thought the VT is driven related to that infralateral ischemia and the left circumflex. They went after that, but we're looking at the interventional aspect of it. Probably they had the discussion with the EP and all that. It could be from scar tissue for all that we know, and the VT may not go away, but they have to try something to decrease the ischemic burden to see if the VT comes down. The guys on mexiletine or amiodarone both, so refractory VT, I guess they want to decrease the ischemic burden and see. So that was the question in terms of how much the CTO will help him clinically with his VT episodes. So all right.
Yeah, I mean, and I think from my experience, and it would be different for different people, but the electrophysiologist was like, I've done everything, and this has to be ischemia. You've got to fix this. And we've done this over the years, where the ischemia does get.
Jabbar, you had a comment?
Thank you, Numan, and Naeem Taib Khiri Saab, this is Dr. Jabbar, and I think it was a very well planned and very well executed case, looking at the risk and planning it according to the risk, putting Ampella and the calcium and many things, and we must congratulate you for this great case. Many educational points.
Thank you, thank you. Say, Heather, do you have any points about this?
I think it's a great learning case. Can you hear me?
Yeah.
So great learning case, and I think the gel balloon technique is very new even for me, and I'm going to start doing it more and more. And I think the wire isolation was perfect. We did find a channel with a feeder XGA wire, but I got stuck with Mongo, and then
The key thing was switching the wire right away quickly rather than trying with the same wire for a long time. And so, we're having troubles with the connection. We're going to sign off. And thank you again. Take care. We're going to be closing the session now.
Thanks. Zabardast Karya.
All right. Thank you, everyone. Dinner 9:15 and inauguration 8:15. It's in the restaurant on the rooftop at 9:15. The dinner.